Hello everyone. Topic for today's presentation is gestational diabetes mellitus (GDM). Diabetes in pregnancy can be presented as either pre-gestational diabetes or gestational diabetes. So what are the cases which are classified as pre-gestational diabetes? So any woman who is showing abnormal plasma glucose level or abnormal HbA1c level in the first trimester or before the pregnancy, then it will be known as pre-gestational diabetes. This pre-gestational diabetes can be either type 1 diabetes or type 2 diabetes mellitus. So as compared to the pre-gestational diabetes, gestational diabetes mellitus are the diabetic cases which are first discovered in second or third trimester of pregnancy in a woman who has no previous history of diabetes. Then it will be labeled as gestational diabetes. It is seen that a large proportion of the diabetes in pregnancy comes under the gestational diabetes. However, it is seen that any woman having type 1 diabetes or type 2 diabetes mellitus in pregnancy has higher risk for having abnormalities in mother as well as baby as compared to those who are having gestational diabetes mellitus. Gestational diabetes mellitus can be defined as any carbohydrate intolerance of variable severity which is onset or first recognized during the pregnancy and ideally in second or third trimester of the pregnancy. Then it will be labeled as gestational diabetes mellitus. Now discussing to the epidemiology of this gestational diabetes. So it is found that the prevalence of this gestational diabetes mellitus varies according to the population studied, the time of testing of this GDM and the criteria used for diagnosis of this gestational diabetes mellitus. However, the prevalence of this gestational diabetes mellitus worldwide is found from 1% to more than 15% in all pregnancies. It is also found that the prevalence of gestational diabetes mellitus in any population is directly proportional to the prevalence of type 2 diabetes and impaired glucose tolerance in that population. It means if the prevalence of type 2 diabetes and impaired glucose tolerance is higher in any population, so definitely there will be higher prevalence of GDM will be found in that population. In respect of India, it is seen the prevalence rate of gestational diabetes mellitus has gone up from 2% in year 1982 to more than 16% in the year 2002. In a multi-centric study in India which was conducted by Sesaya et al. In year 2004, it is found that among all the states of India, the lowest prevalence of gestational diabetes mellitus was found in Kashmir. However, the highest prevalence of GDM was found in Tamil Nadu. Now discussing to the pathophysiology of gestational diabetes mellitus in pregnancy, it is found that women with gestational diabetes mellitus are unable to increase their level of insulin at a sufficient level required to overcome the insulin resistance which is produced during the pregnancy, and the insulin resistance usually increases in the second trimester of the pregnancy due to placental hormonogenesis. That's why this gestational diabetes mellitus is usually common between the 24th to 28th week of the gestation. The physiology of insulin during pregnancy usually depends on the two factors, the insulin sensitivity and insulin resistance. It is seen that the insulin sensitivity usually increases during the early pregnancy, during the first trimester of the pregnancy. However, the insulin resistance usually increases during the second and third trimester. That's why the gestational diabetes mellitus is common during the second and third trimester. It is seen that in women with pre-existing diabetes and gestational diabetes, the pancreatic secretion the secretion of insulin is not sufficient to compensate this insulin resistance, which is common during the second and third trimester. That's why the hyperglycemia or increase in blood glucose level takes place or common during the second and third trimester. In other aspect of the physiology of this insulin, it is seen that during pregnancy, during second and third trimester, there is alteration in the counter regulatory mechanism in the body, and because of that there is reduction in the hypoglycemia unawareness among the pregnant women. In the immediate postpartum period, it is seen that during placental delivery there is rapid decline of this insulin resistance, and due to this the lesser amount of insulin is required during the immediate postpartum period. The HbA1c level is usually affected by the red cell turnover in the pregnancy as well as by the blood loss during the delivery. It is found that the OGTT, oral glucose tolerance test, is the preferred method for the monitoring of glycemic level, blood glucose level during the pregnancy as well as during the immediate postpartum. Now let's discuss the implications of this gestational diabetes mellitus among the pregnant ladies and the infants and the fetus. It is seen that the women with gestational diabetes mellitus are usually normoglycemic during the first trimester, as we have already discussed that the gestational diabetes mellitus is very common during the second and third trimester as compared to the first trimester. As the first trimester is the period of organogenesis, that's why the babies of gestational diabetes mellitus mother have lower risk of having congenital anomalies as they have already crossed the period of organogenesis. However, it is seen that the risk of macrosomia, stillbirth, prematurity, difficult labor and neonatal metabolic complications are higher among the gestational diabetic mellitus mother as compared to the normoglycemic mother or mother who are not having any kind of diabetes during the pregnancy. It is seen that the infant of mothers with GDM are at higher risk of developing obesity, metabolic syndrome and type 2 diabetes mellitus in their later life. The women with gestational diabetes mellitus have higher risk of developing type 2 diabetes later in their life. So, what are the risk factors among the mothers, among the pregnant ladies if they are having diabetes? So, the first risk factor is spontaneous abortion. The fetal death is very common among such ladies. There is problem with shoulder dystocia. This shoulder dystocia is a mechanical problem when there is difficulty to deliver the shoulder of the fetus during the vaginal delivery, and there is requirement of some additional delivery maneuvers so that successful delivery of baby can be done. Apart from that, it is also associated with the congenital development of congenital anomalies. Macrosomia is also very common among the fetus of such diabetic ladies. Macrosomia means the size of the baby is usually bigger as compared to the normal babies. There may be chance of neonatal hyperglycemia and the baby can have respiratory distress syndrome as well. Now let's discuss to the screening methods for the diabetes, gestational diabetes among the pregnant women. So it describes about the universal screening as compared to the selective screening. So American Diabetes Association ADA recommends for the selective screening. It means screening should be recommended only for the high risk groups. There is no need for the screening for the low risk groups, and these low risk groups includes if the age of the pregnant woman is less than 25 years, if the weight of such woman is normal before the pregnancy, if she belongs to an ethnic group where the prevalence of gestational diabetes mellitus is very low, there are no known diabetic patients in first degree relatives, there is no history of abnormal glucose tolerance in such pregnant women, there is no history of poor obstetric outcome earlier. However, as compared to this selective screening, the Indian scenario, the Indian guidelines recommends for the universal screening, as the Indians are always at high risk for the development of gestational diabetes mellitus. So, this Indian scenario recommends that all pregnant Indian women should be screened for the diabetes. So, question arises, when to screen any diabetic, when to screening any pregnant lady. So, screening should be done as early as possible during the gestation, during the first visit, antenatal visit of the woman. If this first screening is found negative, then we need to again repeat such screening at 24 and 28 week of gestation, as we have already discussed that the gestational diabetes mellitus is usually common or commonly diagnosed during the 24 to 28 weeks of gestation. So, test for screening we must apply our estimation of the fasting plasma glucose, the 2-hour plasma glucose estimation after consumption of 75 gram of oral glucose, estimation of level of HbA1c, and we can also use the estimation of the random plasma glucose level. Now let's discuss about the diagnosis of gestational diabetes mellitus. So, as per the IDPSG recommendations, this IDPSG stands for the International Association of Diabetes in Pregnancy Study Group. As per this recommendation, the plasma glucose is recorded at fasting level, and it is also recorded after giving 75 gram of glucose, and this level of plasma glucose is recorded after the 1 hour of consumption of the 75 gram and after 2 hours of the consumption of this 75 gram of glucose. If any one value is abnormal, then it is sufficient for the diagnosis of the gestational diabetes mellitus, and these are the level or parameters for the diagnosis of the gestational diabetes. If fasting glucose level is more than or equal to 92 mg per deciliter, if 1 hour plasma glucose level is more than or equal to 180 mg per deciliter, and if 2 hour plasma glucose level is more than or equal to 153 mg per deciliter. But this IDPSG recommendation has some disadvantage, as these criteria may lead to overdiagnosis of the gestational diabetes mellitus among the pregnant women in India. So, this IDPSG recommendation is only been accepted by the American Diabetes Association and the WHO. In India, we follow the DIPSI guidelines for the diagnosis of GDM. The DIPSI guidelines has two strategy, the one-step strategy and two-step strategy. In India, for convenience, we usually follow the one-step strategy for the diagnosis of the GDM. In this, as per this one-step strategy of DIPSI guidelines, we perform the oral glucose tolerance test by giving 75 gram of glucose to the pregnant lady, and the plasma glucose levels are recorded after 2 hours of the consumption, and diagnosis is made accordingly. If the plasma glucose level after 2 hours is more than or equal to 200 mg per deciliter, then it is labeled as diabetes. If the plasma glucose level is between 140 to 199 mg per deciliter, then this is labeled as gestational diabetes mellitus GDM. This DIPSI guidelines also tells that the glucose tolerance test can also be administered in the non-fasting state, and the evidence of this non-fasting state GTT are equivocal. They are as accurate for the diagnosis of the GDM. As I have already mentioned that there is two-step strategy also under the DIPSI guidelines, and in this two-step strategy the plasma glucose is measured in non-fasting pregnant women in first step. In this we give around 50 gram of oral glucose, and the level of plasma glucose is measured after 1 hour of the consumption. If the level of plasma glucose after 1 hour is more than 130 milligram per deciliter, then we need to go for the second step. In the second step it is performed among the fasting pregnant women, and here the oral glucose tolerance test is performed after giving 100 gram of the glucose to the such pregnant lady. For the diagnosis of gestational diabetes mellitus, at least 2 of the value should be abnormal out of these 4 values. The fasting level is if more than 105 milligram per deciliter, 1 hour plasma glucose level is more than 190 milligram per deciliter, 2 hour plasma glucose 165 milligram per deciliter, and 3 hour plasma glucose level is more than 145 milligram per deciliter. So for positivity of this gestational diabetes mellitus, at least 2 values out of these 4 values should be positive. The 1-step and 2-step strategy, both the strategies is only performed among the women who are not having any gestational or pre-existing diabetes during the 24 to 28 weeks of the pregnancy. In the second part of this presentation on gestational diabetes mellitus, we will discuss about the management of diabetes during the pregnancy, which includes the pre-pregnancy control or counseling, the control of blood glucose during the pregnancy, and post-pregnancy control of the blood glucose. Thanks for watching this video. For the second part of this presentation on gestational diabetes mellitus, please follow the next video.